Welcome back to the deep dive. Today we are undertaking a really complex, high-stakes analysis of structural failure in the human body.
We certainly are.
We're looking at a surgical challenge so profound it requires not just repair, but total anatomical reconstruction. A
hmm
situation where the body literally, and I mean literally, loses the capacity to contain its own organs.
That's right. We are deep diving into the management of massive abdominal wall hernias, and specifically this condition known as loss of domain, or LOD.
And this is so much more than a routine hernia repair, isn't it?
Oh, a whole different world. This is a failure of the container itself. Our mission today is to really unpack the source material and understand the detailed surgical choreography.
So we're talking pre-surgical steps, the actual reconstruction.
Everything. We'll cover the mandated pre-surgical steps needed to make space again, and then we'll analyze the competing structural solutions. The component separation techniques, or CSTs, used to rebuild the abdominal wall.
This feels like a masterclass in adaptation. We're moving way past simple patching and into this high-level critical thinking about body mechanics, about surgical strategy.
Mm,
For those of you who appreciate complex systems and surgical innovation, understanding how surgeons manage LOD is, well, it's essential to grasping the frontier of abdominal reconstruction.
indeed. We're aiming to understand not just the techniques themselves, but the detailed why behind these critical steps.
Why do you need to precondition the patient? Why is one surgical plane better than another?
Exactly. It's the difference between, say, seeing a car get fixed and actually understanding the physics of the engine replacement.
Let's get into it. So let's start at the beginning, defining the scale of this problem. The source material uses this really striking, if a little morbid, description of LOD. It says, when the hernia becomes home.
It's the perfect metaphor.
It is, isn't it? It implies this permanence, this functional shift that changes the patient's entire physiology.
And it really highlights the time component. Loss of domain occurs when a massive incisional hernia, often from previous failed surgeries or major trauma, allows the abdominal organs.
The intestines, everything.
Everything, the small and large intestines, the omentum, they migrate entirely out of the standard abdominal cavity and into the hernia sac, and they live there permanently.
And crucially, they stay there long enough for the body to physically readjust to them being gone.
Exactly. The body is just a fantastic example of use it or lose it adaptability. The abdominal cavity, which is, normally responsible for containing all these organs, it perceives itself as being empty.
So it changes shape.
It shrinks. The lateral abdominal wall muscles, the obliques and the transverses, they contract and they shorten over months or years. The diaphragm actually descends lower. The literal volume of the abdominal cavity shrinks. It's a process called viscerosclerosis.
So this shrunken, stiffened cavity, it can't just take the organs back.
You can't. There's no room. Trying to force them back in would be a catastrophe.
Okay, the furniture analogy in the source is good, but let's try to find a more sophisticated way to frame this for, our listeners. Something maybe from architecture or engineering.
That's a great idea. Think of the abdominal core as a highly pressurized suspension bridge system.
Okay.
The abdominal wall is this combination of muscles and fascia, and it's all designed to bear significant internal load and maintain core stability.
Right, it's a dynamic container.
When a massive hernia occurs, it's like a catastrophic failure of the central support beam. The contents spill to the exterior, and the internal structure, the remaining abdominal wall, it just slacks. It stiffens in that relaxed position.
So trying to put the contents back.
It's like trying to retension a completely collapsed suspension bridge. The stress on the points of closure would be immediately catastrophic.
Yeah.
You have to rebuild the supports first. You have to stretch the cables back out before you can put the road back in.
So how does a surgeon differentiate? How do they know this isn't just a very large hernia you can fix with a standard mesh patch, but a true case of LOD that needs this whole intensive reconstruction?
Well, clinically, it starts with observation. These patients often present with massive, non-reducible hernias.
Meaning even when they lie flat, the organs don't slide back in.
They don't. And often, the remaining abdominal wall looks scaphoid, concave, because all the contents are externalized. But just relying on observation isn't enough. It's too subjective.
So you need objective measurement, and that brings us to the gold standard confirmation method, the one we see on CT imaging.
Yep.
The Tanaka index.
The Tanaka index is the absolute cornerstone of LOD diagnosis. It gives you a quantitative, objective measure of the volume mismatch.
So it's a ratio.
It's a ratio, yes.
Oh.
It compares the hernia sac volume, to the volume of the original remaining shrunken abdominal cavity.
Yeah.
So you calculate it by dividing the Hernia sac volume by the abdominal cavity volume.
What are the radiologists actually looking for when they calculate these volumes on a CT scan? Is it a complicated process?
It's detailed work. They use specific anatomical planes and landmarks. The key is to measure the volume contained within the fascial boundaries of the abdominal wall, usually from the dome of the diaphragm down to the pelvic brim.
And they trace it out.
They use 3D reconstruction software to trace the internal boundary of that shrunken cavity and then the external boundary of the hernia sac.
And what's the magic number, the critical threshold?
LOD is confirmed if the Tanaka index is greater than 25%.
25%.
Yes. That means that the contents living outside the cavity take up more than 1/4 of the space of the shrunken cavity itself. Crossing that 25% line fundamentally changes everything about your surgical management.
So if you're at 20%, you might try something else.
You might attempt a slightly modified closure, sure, but at 26%, you must initiate prehabilitation and plan for a specialized component separation. There's no other safe way.
This quantitative approach is so vital. But let's talk about the immediate life-threatening risks. Why can't you just use surgical brute force? Just pull the edges together and sew.
Because the danger is immediate physiological collapse. It all comes down to pressure.
Right.
When you cram the organs back into a space that's too small, the pressure inside the abdomen, the intra-abdominal pressure, or IAP, it just spikes. This leads directly to abdominal compartment syndrome, or ACS.
And this isn't just, discomfort. This is a full-blown emergency where that pressure compromises every major body system.
Absolutely. The primary effect is on the cardiovascular and respiratory systems. High IAP shoves the diaphragm upward, massively restricting lung expansion.
So they can't breathe.
They can't breathe.
Yeah.
It leads to acute respiratory distress and failure. At the same time, that pressure compresses the large veins, the vena cava, which hinders blood return to the heart. So cardiac output plummets, and you get systemic hypotension.
And the kidneys suffer severely from this, correct?
They are exquisitely sensitive to perfusion pressure. High IAP compresses the renal arteries and veins, leading to acute kidney injury and eventually multi-organ dysfunction.
A complete cascade.
A lethal cascade. And that's why ignoring the LOD threshold is just unacceptable. The specialized techniques we're about to discuss are purely about preventing this outcome by creating space safely.
Okay, so if the core issue is that the cavity has shrunk and the muscles have tightened, then the first logical step must be to stretch and relax the system before you even open the patient up.
Yes.
And that's the entire philosophy of prehabilitation or prehab in LOD management.
Prehab is absolutely non-negotiable for anyone over that 25% Tanaka threshold. It's not optional. We need to physically restore volume and chemically relax the resisting forces. And we use 3 primary evidence-based methods to do that.
Let's start with the one that sounds, frankly, a little counterintuitive, progressive pneumoperitoneum, or PPP. You're intentionally inflating the abdomen with gas.
It does sound counterintuitive, I agree, but it's highly effective. PPP involves the slow, controlled, and often intermittent injection of gas, usually just room air, though sometimes filtered CO2 into the peritoneal cavity.
How do they get it in there?
It's typically done through a percutaneously placed catheter. And this is done over a period that can last from 1 week up to 4 weeks, sometimes even longer, depending on the volume you need to gain back.
Why is gas, like air or CO2, preferred over something like saline? And why the slow, weeks-long process?
Well, the benefit of gas is that it provides a constant, gentle, mechanical stretch without adding significant weight, which saline would. The slowness, though, that is the crucial element.
Because if you did it fast.
If you inflated the abdomen rapidly, you would trigger the very compartment syndrome you're trying to avoid. By doing it progressively, sometimes adding just small volumes daily, you allow the viscoelastic properties of the abdominal fascia and the muscles to stretch slowly and safely. It's like gently expanding a balloon over time.
So it's a controlled therapeutic expansion. How is the patient's tolerance and the effectiveness of this stretching monitored during this period?
Monitoring is critical. They are watched closely for pain, respiratory status, and crucially, abdominal girth. You're literally measuring the expansion.
And there's a goal.
Yes. The surgeon usually has a goal, often defined by needing to achieve an additional 10 to 15 centimeters in girth measurement, or when a repeat CT scan shows adequate volume restoration. Once you hit that goal, the surgery can be scheduled. This process transforms what would be a high-risk, tension-filled closure into something manageable.
Okay, so that's the mechanical stretching. Now for the second key step, the truly unique chemical component. botulinum toxin injection, Botox. We all associate this with cosmetics, but here it's a critical mechanical relaxant.
The application here is just ingenious biomechanics. Botox, as we know, temporarily paralyzes the target muscle. It does this by inhibiting the release of acetylcholine at the neuromuscular junction.
And in LOD patients, it's injected into where specifically?
It's injected strategically into the lateral abdominal wall muscles, primarily the external oblique and the internal oblique on both sides.
And why specifically those lateral muscles?
Because they are the muscles that have tightened and shortened over years. They provide the most significant resistance to pulling the rectus sheath back to the middle. By paralyzing them, you just remove that resisting tension.
It's like cutting the ropes in a tug-of-war.
It is. And the effect of the Botox peaks around 2 to 3 weeks after injection, which is perfectly timed to coincide with the planned date of the surgery.
Now, this is a challenging point. If you're temporarily paralyzing key core musculature, what is the critical risk here? Does this compromise the patient's core stability long term, especially if they're already functionally compromised?
That is an excellent critical question, and the key word is temporarily. The paralyzing effects of botulinum toxin typically last 3 to 6 months.
Okay.
Surgeons rely on the fact that by the time that effect wears off, the reconstruction is complete, the fascia is closed, and the mesh is integrated and providing structural support.
So the new structure takes over before the paralysis wears off.
Exactly. But for the first few months, yes, the patient is dependent on external support, like an abdominal binder, and must engage in rigorous physical therapy. If the effects of Botox were permanent, it would be functionally disastrous. But its temporary nature is what makes it such a powerful prehab tool. It reduces acute tension without permanent functional loss.
So we have the stretching agent, PPP, and the relaxing agent, Botox. What about the foundational supportive steps, the things that ensure the patient is even ready for the stress of this kind of reconstruction?
We cannot overstate the importance of systemic optimization. Nutrition optimization is paramount.
Right.
A major abdominal wall reconstruction involves huge fascial incisions, extensive dissections, and putting foreign material, the mesh, into the body. Poor nutritional status, especially protein deficiency, means the body just lacks the building blocks to heal.
And that leads to much higher complication rates.
Dramatically higher rates of surgical site infections, delayed wound healing, and recurrence. It's a non-starter.
And given that we're physically compromising their lung function by pushing that diaphragm back up, pulmonary preparation must also be key.
Absolutely. Pulmonary prehab is vital. Patients with these massive hernias have often adapted to breathing very shallowly. When you return the contents, the diaphragm is suddenly pushed cephalid, or upward, which reduces their vital lung capacity.
So you have to train their lungs for the shock.
You do. Preoperative training with incentive spirometry and respiratory muscle exercises helps them cope with that immediate post-operative loss of volume. It reduces the risk of pneumonia and the need for mechanical ventilation. Success in LOD repair is built on weeks of meticulous preparation before the first incision is ever made.
Okay, the prehab is complete. The space has been created, the muscles are relaxed. Now we move to the main event, the component separation techniques, or CSTs.
Main event.
This is the surgical act of freeing up the layers of the abdominal wall to allow the midline fascia to be brought back together without any residual tension.
That is the core objective, tension-free fascial closure. CST is necessary because just, reducing the contents and trying to sew the edges together, what we call primary closure, would result in high tension, immediate fascial tearing, and almost certain recurrence.
It would just rip apart.
Immediately. So these muscle releases mobilize tissues that become fixed way out on the sides.
Historically, surgeons approach this problem from the outside, using the classical technique. Let's dissect the anterior component separation technique, which was pioneered by Dr. Oscar Ramirez.
The Ramirez technique, or anterior CST, it really revolutionized hernia repair decades ago. It involves working from the skin inward. The anatomical target is the external oblique aponeurosis.
Can you just explain what an aponeurosis is for our listeners to keep the terminology clear?
Of course. An aponeurosis is essentially a broad, flat sheet of tendon. It's tough, fibrous tissue. In this case, it's what connects the muscle belly of the external oblique to the rest of the abdominal wall.
So the surgeon cuts this sheet.
Yes, they make a long incision in this sheet, lateral to the rectus muscle sheath, usually along a landmark called the linea semilunaris.
And by cutting that outer layer, what happens to the muscle layers underneath it?
By releasing the aponeurosis on both sides, the entire complex of the underlying muscles, the internal oblique, the transversus abdominis, and the rectus abdominis, is freed from the tension of that outermost layer. This allows the whole rectus muscle sheath to slide medially towards the center.
You're essentially decoupling the external restriction.
Precisely.
And the gain in space is significant here, right? Up to 10 centimeters per side.
That can be, yes.
But the source material gave us that crucial warning. Anterior CST trades skin perfusion for medial advancement. Let's detail the steps to explain why this trade-off is required and why it's so risky.
Okay, so to even get to that external oblique aponeurosis, the surgeon has to raise large, thin skin subcutaneous flaps.
These are big flaps of skin and fat.
Huge flaps. They're dissected laterally across the entire abdomen, often reaching the lateral border of the rectus muscle sheath, sometimes even further. This extensive dissection is necessary just for visualization and to make that incision.
Why does raising those flaps compromise the skin's blood supply so badly?
The skin of the abdomen gets its blood supply primarily through these small vessels called perforators. They come vertically up from the underlying muscles. When the surgeon dissects those skin flaps, they are inevitably dividing those crucial perforators.
You're cutting the lifelines to the skin.
You are. This dramatically reduces the perfusion to the edge of the skin and the underlying fat.
And the consequence of that reduced perfusion is what has made this classical technique fall out of favor then.
Precisely. The extensive dissection and flap creation dramatically increase the risk of superficial complications. We are talking about flap necrosis, where the skin edges literally die due to lack of blood flow.
Which requires more surgery, debridement.
Painful debridement, delayed healing, it's a mess.
Mm.
This massive surgical field also significantly increases the rate of surgical site infection, SSI, and seroma formation, which are these large collections of fluid under the skin flaps.
And the mesh placement is also a problem here.
A huge problem, because the mesh is often placed superficially, either onlay on top of the closure or inlay. It's exposed to this contaminated or poorly perfused environment. That leads to much higher rates of mesh infection and ultimately recurrence. The superficial complication rate of anterior CST is the main driver of its high recurrence rate.
So the challenge for surgeons became, how do we achieve the same medial advancement but eliminate the risk of all these flap-related complications?
Yep.
And that led to the development of the preferred modern technique, the posterior component separation technique, or specifically the transversus abdominis release, TAR.
The TAR.
This approach, as the source states, restores the domain from the inside.
It's a revolutionary technique, credited largely to surgeons like Dr. Yuri Davitsky. And it is fundamentally different because the surgeon never raises those extensive superficial skin flaps. They work deep within the abdominal wall layers, behind the rectus muscle, hence the term posterior.
What is the specific anatomical pathway the surgeon takes to achieve this internal release? It sounds much more complex.
It is more complex. The surgeon begins with a midline incision, they reduce the hernia contents, and then they enter what's called the retrorectus space.
Behind the six-pack muscle.
Yeah, exactly. They incise the posterior rectus sheath, the fascial layer behind the rectus muscle. This is then developed laterally all the way to the linea semilinoris. This retrorectus space gives you a relatively clean, protected working area to start from.
That space is already there anatomically, but the key release happens next, right?
That's right. This is the TAR part. Once they reach the linea semilinoris, instead of stopping, the surgeon continues the dissection even deeper, releasing the transversus abdominis muscle, the TA muscle, from its posterior attachments.
So you're dividing the deepest of the three lateral abdominal muscles.
Yes, and dividing the TA muscle allows the surgeon to peel back the entire rectus oblique unit and enter a gigantic new space, the retrotransversus plane, or preperitoneal space.
Wow. That sounds far more structurally significant than just cutting an outer aponeurosis. What does creating this deep plane achieve?
It creates a vast, clean pocket that extends from the costal margin, the ribs, all the way down to the pelvis, and critically, laterally, to the psoas muscle in the flank.
A huge space.
Huge space. And it's behind all the muscle layers and in front of the peritoneum. This is the ideal anatomical location for what we call the sublay mesh position.
Let's elaborate on why that sublay position is considered the gold standard, biomechanically speaking.
Well, biomechanically, it's superior because of physics. Plain and simple. When a patient coughs or strains or just sits up, their intra-abdominal pressure increases, right?
Right.
If the mesh is placed onlay superficially, like in the Ramirez technique, that pressure pushes the repair outward. It creates stress on the sutures and can cause recurrence.
But with sublay,
The mesh is behind the muscle. So the intra-abdominal pressure actually pushes the viscera against the mesh, holding it securely in place and reinforcing the repair. It's like using the body's own internal pressure to seal the repair. It's a highly favorable mechanical environment.
Okay, but the lateral dissection to release that TA muscle, that sounds like where the complexity spikes and where the risk of critical neurological injury lies.
Absolutely. This is the single highest skill requirement of TAR. As the surgeon works laterally to divide the TA muscle, they have to navigate the neurovascular bundles.
The nerves and blood vessels.
The nerves and blood vessels that supply the core abdominal muscles, the rectus, the internal oblique. These bundles emerge from the posterior plane and travel medially.
And if you damage those nerves during the release, what happens then?
Damage to these motor nerves can cause segmental denervation that results in permanent weakness or even paralysis of sections of the abdominal wall.
So you get a bulge anyway.
You get a functional bulge, chronic flaccidity, and severe pain. The surgeon has to meticulously preserve these bundles. It requires exceptional anatomical knowledge to identify the correct plane and spare those structures.
And what's the advancement gain here? Is it as much as the anterior technique?
It's typically 6 to 8 centimeters per side, so slightly less than Ramirez, but it's usually more than sufficient when you've combined it with the prehab.
And the closure is much more robust.
Much more. It's a two-layer closure. The posterior fascia is closed first, the wide sublay mesh is placed and fixed, and finally the anterior rectus sheath is closed, achieving that tension-free approximation. Then you close the skin, all without that devastating subcutaneous dissection.
Okay, let's bring this back to a clear comparison, a head-to-head. We're contrasting two surgical philosophies,
Sure.
one from the outside in, one from the inside out.
Right. The contrast is all about the anatomical plane of the release and the resulting environment for the mesh.
So starting with the plane of operation, anterior CST releases
The external oblique eo aponeurosis, the most superficial layer.
while posterior CST, the TAR, releases.
The deepest muscle, the transversus abdominis TA, creating that huge retrotransversus plane.
Okay. In terms of skin flaps, which is the source of so many complications, anterior CST
Requires extensive bilateral flaps, no way around it.
and posterior CST.
Avoids them completely. You're only making the standard midline incision.
The resulting mesh position is dramatically different. Anterior CST often results in,
An onlay or inlay position, which is, as we said, mechanically less favorable.
and TAR enables the.
The sublay position.
Yep.
Deep within the retrotransversus space, that's the gold standard. Superior biomechanical strength, lower exposure to infection.
Consequently, the complications profile is almost an inverse. Anterior CST has a high incidence of,
Superficial issues.
Yeah.
Flap necrosis, SSI, seroma, all wound-related.
and TAR, despite its technical difficulty, results in.
Significantly less superficial wound complications, which leads to a much, much lower recurrence rate.
And finally, the learning curve required to master these approaches. Anterior CST is noted as,
Moderate. A competent general surgeon can learn it.
but TAR.
The TAR technique requires exceptionally precise anatomical knowledge and deep surgical experience. Its learning curve is definitively high. This isn't a technique performed by every general surgeon. It requires specialized training in complex abdominal wall reconstruction.
Before we move on to post-op care, let's just nail down the key foundational requirements for success in these complex LOD cases.
There are two foundational tenets, and they're inseparable. First, you must have a tension-free fascial closure. That's the whole purpose of the CST. If the edges are pulled taut, the repair will fail, no matter what mesh you use.
And second,
Second, mesh is mandatory for a durable repair. The CST fixes the tension problem. The mesh fixes the recurrence problem. Using a large, well-placed mesh in that sublay position provides the necessary permanent structural reinforcement. Without both, the repair is compromised. And of course, for LOD, the prehab must precede everything.
the surgical reconstruction is complete, the tension-free closure is secured, the domain has been restored, but the body has just had a huge volume of viscera returned to a cavity it had forgotten existed. The risk of abdominal compartment syndrome doesn't just vanish when the patient leaves the OR, does it?
Not at all. The monitoring phase is absolutely critical. This is a period of intense vigilance, typically lasting the first 48 to 72 hours post-operation.
Right.
The body is adjusting to a sudden, significant increase in intra-abdominal volume, which raises the baseline pressure. So surgeons and the critical care teams are meticulously monitoring for any signs of that pressure creeping up to dangerous levels.
You mentioned monitoring 4 key signs earlier. Let's detail the metrics they use. How do you measure that pressure directly?
Well, direct measurement is invasive, so it's typically monitored indirectly using a bladder pressure measurement. A catheter is inserted, and the pressure in the bladder correlates very reliably with the intra-abdominal pressure, the IAP.
And what are the numbers they're watching for?
Normal IAP is typically below 10-12 millimeters of mercury. If the pressure starts rising toward 20 millimeters G or higher, that's a surgical alert. Sustained pressure above 25 millimeters G constitutes full-blown ACS and requires immediate intervention.
What are the physiological indicators that signal that high IAP is starting to compromise the patient systemically?
The very first indicator is often reduced urine output. The kidneys are so sensitive. If they're being compressed, their perfusion decreases and urine output will drop significantly, below 0.5 milliliters per kilogram per hour.
Huge red flag.
A huge red flag.
Okay.
And second, respiratory distress becomes obvious. Tachypnea or rapid shallow breathing. That indicates the patient can't expand their lungs adequately because the diaphragm is being pushed up.
And what about the physical examination? How does the abdomen actually feel?
The abdomen will be distended, that's expected. But crucially, it will be tense and firm to the touch. An extremely firm, rigid abdomen in the context of rising IAP and failing organ function is the clinical picture of full-blown compartment syndrome.
And if that happens?
If monitoring shows these signs are escalating despite conservative management, the surgical team may need to go back to the OR. They might need to perform a staged closure or even temporary surgical decompression to prevent fatal multi-organ failure.
It sounds like the structural rebuilding is only half the battle. The patient then faces this long recovery to retrain that newly reconstructed core.
Absolutely. The postoperative recovery involves a period of gradual mobilization and eventually specialized physical therapy. They have to rebuild the strength of their core muscles, which have been surgically divided or paralyzed, but now they're doing it against a stable, tension-free fascial closure reinforced by mesh.
The goal is full functional recovery.
Full functional recovery, allowing them to lift, bend, and move without recurrence. This requires months of commitment to rehabilitation.
This whole journey from the diagnosis with the Tanaka index through weeks of pneumoperitoneum and Botox to the high-skill TAR procedure and then the intense post-op monitoring, it's just a massive undertaking.
It is. For both the patient and the surgical team, it really emphasizes...
It integrates so many disciplines.
It does. And this holistic view brings us back to that powerful concluding synthesis from the source material. It just perfectly summarizes the philosophy of LOD management. A house cannot hold its guests unless it remembers they once lived there. Loss of domain must be treated before re-entry.
The surgical act of reentry is impossible if the body hasn't first been convinced through PPP and Botox that its structural capacity is ready for that volume again.
Beautifully put.
And that concludes our extensive deep dive into loss of domain and the revolutionary component separation techniques. We've established the two main reconstructive philosophies: the classical anterior CST, the Ramirez technique, which achieves maximum advancement but at the cost of potential skin and wound complications.
All due to that extensive flap dissection.
And then the superior high-skill posterior CST, or TAR, which restores the domain internally, allowing for that biomechanically favorable sublay mesh position and significantly lower recurrence rates.
The differentiation is philosophical, really. It's whether you accept a high superficial wound risk to get maximum space, or whether you prioritize a clean, deep mesh environment for long-term durability, even if it demands a much higher surgical skill ceiling.
And the gold standard has clearly shifted.
The fact that the gold standard now moves into the deepest layers of the abdominal wall, it just underscores this focus on long-term functional outcome over a simple immediate closure.
And that leads to a profound thought for you, the learner, to consider. We spent a lot of time detailing the preconditioning, the PPP, and the Botox, which uses sustained mechanical forces and chemical intervention to physically teach the abdominal structure its original functional volume.
We often think of surgery as a single, decisive event. But here, the success hinges entirely on mechanical and chemical preconditioning that takes place over weeks. What does this reveal about the sheer adaptability of the human body's fascia and muscle structure? That it can be successfully retaught or reshaped through sustained, non-surgical methods.
Think about that capacity. Where else in reconstructive or, say, orthopedic surgery might we be underutilizing the power of mechanical preconditioning to reduce surgical tension and risk, ensuring the ultimate success of complex interventions?
The lesson of LOD is that the preparation is often more critical than the procedure itself.
Keep asking those questions and keep exploring the complexity. Thank you for joining us on this deep dive into abdominal reconstruction. We'll see you next time.